This research started about 5 years ago in 2011. Tim and I had not actually ever worked together before, but we were both approached separately, me partly because I'm a community engaged researcher, and Tim because he's a leader in the province around substance use research. We were approached separately because in Vancouver they were starting a managed alcohol program, and they said, you know, when we start the program, we'd like to evaluate it. And that's kind of a researcher's dream, because you get a chance to see how the program is developing and unfolding. And so we started with that one small project to evaluate it, and it's now grown into a national study that includes 6 programs in 5 cities. So I'm going to start, and I'm just going to tell you a little bit about managed alcohol programs, what they are, why we need them, and some of the initial research from those initial studies that we did in Vancouver and then in Thunder Bay. And then Tim is going to talk about the findings, our very first findings from the national study. And our national study has a large team, and this picture was taken about 3 years ago at one of our first team meetings in Toronto, and it actually doesn't quite represent everyone who's on the team, but it's a mix of both academic researchers and people who are working in the field, practitioners. So there's people on the team who are running managed alcohol programs. There are people on the team who have maybe participated in a managed alcohol program, as well as people who are in government and are policymakers. So a very big team, because we want our research to be rigorous, we want it to be scientific, but we also want it to be used. And so that's why we have that kind of team. So we're funded by the Canadian Institutes of Health Research currently. We have just completing one 3-year study and starting the next 3-year study. And then we're also funded by a BC Foundation, Michael Smith Foundation for Health Research, and then Shelter House in Thunder Bay, Vancouver Coastal and Canadian Mental Health Association in Sudbury are also funding the research, because we've been doing program evaluations with each of them as we've been going. So I think, you know, we're all aware that there's a high rate of alcohol use in the population. In a Canadian population, it's probably around 80%. But alcohol dependency affects only about 3 to 4% of the general population. In the homeless population, the rates of drinking probably are a bit less than the general population. We just did a small study here in Victoria, and we found that among the homeless population, only about 66% of them actually drink alcohol, and that's any kind of use. That could be 1 drink in a month. But what we often find when you look at research is the rate of severe alcohol dependence in homeless populations, particularly most of the research has been done with men, there's very little with women, is often very high. It can be up to 50, 60, 75% of the population, depending on the location, that are affected by severe alcohol dependency. So there's a lot of harms, and you'll notice our question is about, you know, can managed alcohol programs reduce the harms? So we're not talking about necessarily reducing use, that may happen, but we're talking about, can we keep people safer? And so this is just a list of the types of harms. Acute harms such as injury, poisoning, chronic harms such as long-term liver disease, cancer, strokes, GI problems, and then social harms where people's housing, their finances, relationships, problems with the law, or their work might be affected. So we are mainly looking at people who have severe alcohol problems and also experiencing homelessness as well. And so how does our community respond to that? Well, typically we may have programs, abstinence-based programs, shelters that say 0 tolerance for alcohol on site, so no drinking is allowed. Sometimes shelters will say, we'll allow drinking, but we're not going to really do anything about it. And that can be true in housing as well. And so managed alcohol programs just go one step further than that for people that aren't going to be able to access this type of housing, where they actually help people with their use and management of alcohol to prevent the harms. This is really significant in our Canadian history. The reason why managed alcohol programs have been developed is because people were dying. They were dying on the streets. And in Toronto, in the sort of late 90s, there were several men who froze to death. And the coroner said, we need to look into what's happening. And what became apparent is that these men were not able to go into shelter. They could not access housing. So they had actually died on the streets. And so the coroner said, you need to develop a program specifically for people. And that really started the first map in about 1998, and it's at Seton House in Toronto. And there's a great story where they started by just sort of saying, you know, we'll keep your alcohol, we'll store it for you, we'll keep you safe so you can come inside. And then they started to realize, they said when the men got up in the morning, they didn't want to stay and eat. They left because they needed to get their first drink in order to prevent them from having a seizure or blacking out. So they thought, well, if we could get them to eat, why don't we start with just serving them a drink? And it was actually initially billed as Perrier water. There was a very wonderful politician whose name was Jack Layton that came along and saw what they were doing and said, you need to tell everybody what you're doing here. And so those first programs started out of a very compassionate response to what was happening among people who were homeless and using alcohol. So the goals of a MAP are to provide people with accommodation of some type because they may not, often do not have housing or very unstable housing, to try to reduce the consumption of non-beverage alcohol and stabilize the use of beverage. So when we say non-beverage, what we mean is things like rubbing alcohol or hand sanitizer that have an alcohol content in it and can often be available or obtained at a very low price, and also to reduce police and emergency service use, because often people may come to the awareness of a community because the police are really frequently being called, or people are being taken to the emerge department. In Thunder Bay, one of the programs we're going to talk about, it was the police who said, what we're doing right now is not working. We have treatment beds, but they're full, we don't have enough of them, and when people come in, they're cycling through them. And they said, we need to do something different, and so they were one of the biggest proponents of the managed alcohol program in Thunder Bay. So we need them to prevent the harms of non-beverage alcohol, binge drinking, and drinking outside in unsafe settings. I have heard stories that would break your heart of what have happened to people who have been in parks, who've been left behind buildings to die, who've been beat up, who've been assaulted, and so the settings in which they're in are very unsafe. And I think, again, communities have said, this isn't acceptable for this to happen to people in our community. And yet we have a lack of treatment options available to them. So have started managed alcohol programs, and most of the research to date has been very much kind of single program kind of evaluations where they followed people in the program, but they didn't necessarily look at people who weren't in the program, but could be. And so when we started in 2011, we said we need to look at both people in the program and compare them to people who are not in the program, so having some kind of control group. There weren't any national studies, so we started just by developing a research protocol that would allow us to rigorously evaluate maps in Canada and generate knowledge and learning about how to implement them, both to get good outcomes and also in terms of a good process. So we've been looking at things like whether or not maps improve health, both in the short term and long term, so thinking about those acute and chronic kinds of harms, whether or not it results in changes in their use of health and police services, whether they have changes in their patterns of using. Are they using more? Are they using less? Are they using the same? And then also to come up with program and policy recommendations, and we're going to share with you a little bit of that at the end. We didn't put too much methodology in here, but because it's a research presentation, just at a high level, we did quantitative surveys with people in 6 different programs. So we asked them about their substance use, we asked them about harms, we asked them about their quality of life, their satisfaction with their housing, and we did that at the start when they came into the program, as well as people who were in the program. And then those people who were new, we followed up and we talked to them every month for actually 12 months. So it's a huge amount of data. And at 6 and 12 months, we did longer surveys, and every month we did short surveys, so we got to know people pretty well. We also did qualitative interviews where we sat and talked with people who were in the program. We talked with the staff. We asked them about how this program was working, what they liked about it, what they didn't like about it, and we looked at a lot of program documents. And we have a huge amount of secondary data from police services, hospital services, and so on, that can help us. So we're drawing from a lot of different sources. So I'm just going to start. So when we started, we were having this really interesting experience where kind of almost weekly, Tim and I were getting these emails from people all across the country saying, I have a managed alcohol program, or do you know about a managed alcohol program? And so we decided to do an environmental scan, and we tried to identify all of the programs that there are in Canada. We found actually 14 of them, and were able to interview 13 of people in, at least one person in each program. We looked at their documents and websites. I visited most of the programs. Tim's been to some. We've got staff that are there regularly at the programs. And so we developed their program descriptions. And if anyone is interested, if you want to pass on, we have a MAP community of practice, which I think some of you know about, where we do presentations and have discussions. And so all of the programs in the research have shared their program with each other. They talk to each other, so it's created a community of people who are interested in this and who can talk to each other about it across the country. And for the practitioners, they found that really valuable because they're learning from each other as part of the research. So here's, as I said, there's 14 programs. They're actually in 7 cities. And interestingly, we didn't know about the Edmonton programs when we started. And Edmonton said, we've got a real problem with alcohol and homelessness. And they said, so they started doing a scan of their own programs because they thought they didn't have any, and it turned out they had 4. And one of them had been running since 1985. Running very informally. And so it actually preceded what we often think of, the first managed alcohol program, which was at Seton House. Following Seton House, one of the most well-known programs is Ottawa. That program's been in the media a lot. The Guardian, the UK Guardian, did a really nice piece on their program a while ago. It's had a lot of, I would say, media attention. Hamilton, there's been a program there since 2005. Calgary has some programs that actually started as early as 2006. And so there you see Vancouver's program, which started in 2011, and that was the start of our research. And since then, Thunder Bay started a program in 2012, and Edmonton has some programs that came online in 2014. And the newest program that we know of is in Sudbury and started just last year. There's one I know planned for London, Ontario, but these are most of the ones that we know of. So you can see sometimes these programs operate under the radar. They respond very compassionately, but they also kind of go about. People may not even know that they're there, doing the work of meeting the needs of people. So when we talk to the programs, what we found is that many of the programs are male only. There are no female only programs. Depending on the program, 10 to 100% of the participants identify as Indigenous. So for example, in Thunder Bay, they have a very high Indigenous population who experience homelessness, and so their program mainly serves Indigenous people. But in Seton House, it's a real mix because of the fabric of Toronto, and so there's a very different makeup of it. So people in the program have long-term alcohol dependence. They've had multiple experience with abstinence-based treatment. They've had chronic or long-term housing instability, and often have high use of police and health services. So a MAP is a harm reduction program. It's focused on reducing harms by regularly dispensing beverage alcohol, but also providing housing and also providing other types of programs that will reduce harms. including consumption of non-beverage alcohol, binge drinking, and public intoxication. So MAP programs have what we call these kind of 3 pillars. They have the alcohol intervention, where alcohol is administered either daily or 3 to 4 times a day. The programs in our study all administer alcohol every 60 to 90 minutes, so they're a very intensive program, but there are programs that administer alcohol every 3 to 4 hours. Usually people are receiving 5 to 6 ounces of white wine or red wine, so a standard drink to a maximum of 11-12 doses a day. But what that means is it's tailored to the person, because you're going to have people of very different physical sizes, ranges, tolerance. There's also a housing intervention, so people, the housing might be supportive housing, transitional housing. Seton House is actually a whole floor in an emergency shelter, and there are some day programs. So Sudbury is a day program, and then they provide people with housing support, so getting them housed off-site. They don't have housing as part of it. People have access to primary care. They have access to food programs. So these are things that they may not have had access to. They may not have had a regular source of health care. Many of the programs have Indigenous programming as well. It could be in the form of an elder who's part of the program. It could be in form of a traditional celebration ceremony, a feast. There's often life skills and recreational opportunities as part of it. And so the MAP is really this whole package. It's not just the alcohol piece. What's kind of interesting is the programs, even though they all do that, they all do what I just described, they're also all a bit different. In some of them, they're very much grounded on Indigenous worldviews and principles, and that's how they operate, and that's their focus, and it's run by there's one in Edmonton, it's run specifically by an Indigenous organization. There are programs that are run by other people who use alcohol and drugs, and so it's really a way of supporting and building the capacity of peers to help other peers, and that's their main focus. And some of them are more focused on biomedical or clinical kinds of focus, or palliative. Seton House has a fairly strong palliative focus, and they actually have a palliative program kind of within, because many people will be at the end of their life and trying to support them to die with dignity. And then some of them have a real focus on, okay, this is a program for now, we're going to help you manage your alcohol, and then in the future we're going to move on. So these programs have different kinds of philosophies. So I'm just going to quickly touch on 2 of the pilot studies we've done so you can see how they work and the effectiveness, and then Tim's going to take over and unveil for you the findings, some of the very first findings from the national studies. So we did 2 pilot studies, one at Keiki Wynn in Thunder Bay, and the other at Station Street in Vancouver. So to answer the question, do these programs prevent harms? The answer is yes. And in both these pilot programs, they reduced alcohol-related harms related to social, legal, financial, less withdrawal, less likely to have seizures, as well as increasing feelings of safety. But they did a lot more than that. In both of these pilots, people retained their housing, and remember, these are people that have been homeless previously, all of them for long periods, and the people that we compared them to remained homeless. So all of our participants started homeless, people in the MAP retained their housing. To me, who works in the area of homelessness, that's significant in and of itself, that they retained their housing where they hadn't before. But then we found out something really interesting, because we asked them about their housing, what they thought about their housing. And one of the things that popped out is they said, well, we really like it. It's a lot more spacious, it's a lot more private, and you could kind of think, well, yeah, compared to being in a shelter on the street, that makes logical sense. But they said it's also much safer than being on the streets or in the shelters. We also asked about their quality of life. And sorry, I should tell you, the blue are the maps and the greens are the controls. And again, an interesting thing happened. The thing that was significant was that within the environment, they said their environment was much safer, and that's what contributed to their quality of life, as well as better relationships, better physical and mental health. So that's where our qualitative data comes in, because we've got all this quant data saying we feel safer, but what does that really mean? What are they talking about? And so this is a quote from one of our participants in Thunder Bay who said, "You feel safe. You feel like you've got a warm place to stay and some home. You're not outside sleeping and wondering what to eat next." And so they were comparing it to being on the streets, to being in the shelters, to being in the jails. Because if you think about it, before the MAP program started, they were moving often between these places. And so the MAP was a lot safer place for them. But it was even more than safer. And this was particularly in the Thunder Bay program, and we're still looking to see how this is going to play out in the national study. But in the Thunder Bay program, people felt that the program was now their family, and that was their home, and that they had a hope for the future that they hadn't had before. And I don't know how much you know kind of about homelessness, but it often comes with sometimes hopelessness. So this is significant. And I think this woman described it really well. She said, "This program has given me hope. It's allowed me to really think about what I want to do with the rest of my life. And because I was stuck, not stuck, I guess you could say, rock bottom, and going home," and she's referring actually to going to her home where she grew up, "couldn't get me out of that rock bottom I was in. But since coming here, I know there's a horizon waiting for me." And she talked about being able to reconnect with her family as was already happening, but thinking about the future, and also the importance of connecting with her cultural roots as well, that she spoke to. So at that point, I'm going to turn it over to Tim. Are you ready?
Yeah, sure.
And he's going to tell you about the rest of the story of the pilots and the national study.
I feel like some kind of robot. So thank you very much. Good afternoon, everybody, and thank you, St. Bernadette, for allowing me to share some of the limelight. We have different deans. Bernie has a Dean of Human and Social Development, and in psychology I have the Dean of Social Sciences, so I'm really infringing in another faculty. Anyway, onwards and upwards. So we're talking a little bit about some of the early findings from our pilot studies, and then I'll talk to you about the national findings. We're going to, with the quantitative data, we're going to try and address some very hard questions. These are controversial programs. The way Bernie put it, you'd think, how could you not support a program like this? It comes from such a good place, a compassionate response, it's so needed. But they're hugely controversial. They've been closed down. Why spend taxpayers' money on giving alcohol to alcoholics? Are you nuts? Have you got rocks in your head? So we're trying to get some really hard answers to some very hard questions, because there's public funding going into this, and so I'm going to show you. We've tried to address those questions in as detailed, quantitative way as we can. So here's a summary from the Vancouver and the Thunder Bay findings. So in both cases, we found evidence of reduced non-beverage alcohol. Now this is from self-report from the staff. But by the way, self-report, you probably think, well, that's not hard evidence. I can assure you from doing research on people's drinking and their substance use, the self-report to researchers is better than a breathalyzer or a drug saliva test. Those tests may not pick up what people have been doing at the time you're interested in. They're not very sensitive. And if they trust you, people trust the research is confidential. They'll tell you a lot more. We know this because the staff of these programs also ask how much people are drinking. Are you drinking outside the program? Oh no. Oh no, no, no. I mean, there's rules. If they're drinking too much outside the program, they might lose their space. What they tell us, we add up all the standard drinks. They tell us, oh, we drink, a keg of beer, or a jug of cooler and hand sanitizer. We work out how much alcohol is in there. What they tell us is double what they're telling the staff, including how much the staff are dishing out. So we know we've got a good handle on their outside drinking. And previous research has kind of ignored this issue. Alcohol is a seriously dangerous drug. And people with severe alcohol dependence, on average, have about 27 years less life expectancy than the average person. So it's a serious, serious deal to be giving people alcohol as part of a health and a program to support their health. So just some background. Less non-beverage alcohol for sure. And Alcohol consumption, unfortunately, in the Vancouver site, there was a lot of outside drinking going on that wasn't being regulated while we were looking at the program. By contrast, in Thunder Bay, it was stable or reduced, and they had much stricter policies in Thunder Bay about outside drinking. They actually had room searches, because if somebody's smuggling booze in, they might be sharing it with the other participants and would undermine the whole program. So it's a little tough. And harm reduction isn't necessarily laissez-faire. It can be tough harm reduction because, you know, it protects, and people welcome a bit of structure. In Vancouver, we had, in both places, we looked at liver function tests. Liver function tests are important because actually you can die from liver failure if your liver's very unhealthy and alcohol causes that. There are tests to see in what state people's liver are in. Unfortunately, the Vancouver site in the early years, and we believe they've responded to some of these problems, there's so much outside drinking going on, it appeared the liver function results were getting worse, and some people had to be sent for detox. That's not to say they weren't benefiting in many other ways, but you know, it's a serious issue as to, you know, whether you're about to die from liver failure. In Thunder Bay, we found that people's liver function test almost invariably went south, and they were getting better. So it's a very sensitive indicator whether people are drinking more or less. So that's kind of important. We also looked at police contacts and emergency department presentations and hospital admissions. And basically, we did this very thoroughly. We went to the main records, the police records and the healthcare records. We looked at what people were doing before they went into the map and after. We compared with controls. And here are our conclusions. There are about 40% fewer police contacts and 30% less time in custody for people on MAP compared with controls. Similarly, nearly 50% fewer hospital admissions, and well, there was less use of detox, which I suppose is not surprising if you're on a managed alcohol program. Look, I'm not going to go into these numbers, but let's just look at these numbers. This is savings per dollar invested. If you add up all those police contacts and the hospital admissions and the ER presentations and the treatment episodes, look at the cost of that, look at the cost of the program. We worked out, it depends how you did it, it was somewhere between 9 cents saved per dollar spent, so you got $1.09 back for $1 spent, to $1.21 back for $1 spent when we did the cost-benefit analysis. So a lot of other programs, Housing First programs, haven't actually necessarily been cost-effective. So this is kind of very important. It's saying that we can save money by investing in these programs. If you're in it, that's, you know, just the financial case. There's obviously a human case to be made as well. So I just wanted some of the conclusions. I just want to focus on a few points here, that there were clear benefits, but it did appear that the way the program was structured was important, and it appeared there was evidence that the Thunder Bay program had more benefits than the Vancouver program. But we wanted to go further and look more widely at other programs. So I'm spinning through these slides a little quickly, because I'm sure you'll have lots of questions. So now I'm going to talk about our national study. Out of the 14 programs we've identified in the first phase of our research, we looked at 6 programs. There are nearly 400 people involved in this research as participants, not nearly 400 researchers, but there are nearly 400 participants, half of whom were involved in MAPS and half were controls. We recruited from the same cities who didn't have access to MAPS, but otherwise had severe alcohol problems and problems with their housing. These little stars going to appear. Oh yeah, that's where they were. So Vancouver, Thunder Bay, Hamilton, Ottawa, and Seton House. Those are the ones in the first phase of our research. Sample size and response rates. This just gives some numbers. If you go down the left, there's the cities. At the bottom, we've got the total numbers. So you can see we have 177 people engaged in MAP programs and 187 controls. And look at, this is kind of remarkable. We had nearly 80% follow-up at 12 months in this research with the MAP participants and 67% with the controls. Although I'm only going to show you these early findings, comparing them at like baseline, and I'll explain still why that is quite informative. Now, who was a control? at each site they had their own criteria for whether you could come in on a map. You couldn't walk in off the street and say, I'd like to drink 10 drinks a day for free. You had to fill certain criteria. And so we tried to operationalise, so what exactly were the criteria, and find people who would meet those criteria in terms of housing instability and severe alcohol problems, but hadn't been on a map or had access to a map. Some are on waiting lists to go onto the map. And the criteria that people were operating, their problems and repeated problems with getting drunk in public places, police contacts, repeated presentations, they tried abstinence programs, they hadn't worked for them, they had severe problems, and often they used non-beverage alcohol. Now, what we're going to do here is we're going to compare three groups of people. We've got a group, these are all our first data. We've got these hour-and-a-half interviews. We collected loads of information. I'm going to talk to you about their drinking and their experience of harms. We've got 65 people newly enrolled in a MAP. On average, they've been there a month, 27 days, but no more than 2 months. We've got 189 controls who have never been on a MAP, but they would have been eligible for their local MAPs. We have 109 long-term people who've been on over 2 years on average, and at least 2 months. Now, Bernie has explained that the people that stay on a MAP, once they get there, they stay, they stick. Very few leave. So it's not like we're getting a lot of selection going on, that the people have stayed there 2 years. All the worst cases have been creamed off. It's just that really the good people are staying. There may be some of that, so these are kind of preliminary findings. But I'm going to compare these three groups and show you some data about how much people are drinking, or how they tell us they're drinking, how much non-beverage alcohol they're using, and whether they're experiencing harms related to their drinking. We're going to compare the two and do some tests. They were, the groups were very similar on gender, all these groups. They were mostly male, divided between Caucasian and Aboriginal mainly, but some other ethnicities as well. Obviously the same city of residence. We made sure they were mostly severely alcohol dependent, so very low stability or high instability. Average age, 45 to 50 years. Now, where there were differences, we could statistically control for these things. I'm going to show you some comparisons, but we controlled for any differences between these groups that we could measure. So we're going to compare on drinking and harms from drinking. So more numbers. So we've got the three groups here, the controls, the people newly enrolled in the MAP, and the long-term MAPs. And the first column is how many days were they drinking out of the last 30? Well, it's not very surprising. If you're on a MAP, you drink more days. I mean, that's what MAPs do. You drink every day. You get up, you have a drink, and mostly you keep drinking till you go to bed. The people in the controls would run out of money, they'd go into jail, they'd go into hospital, so they weren't drinking as many days. So, but on the days they were drinking, this is the second column, this is the number of standard drinks. Standard drink, imagine these are a beer, a shot of spirits, a glass of wine. On average, the controls were having 22 of those a day when they drank. The MAPs 20, and the people on the MAP program, remember this is self-report to the research team, not to the staff, who they would lowball estimates. So we're getting significantly fewer drinks per day for people who have been settled down on the MAP. Drinking non-beverage alcohol, let's just say the number of days that they've done that, or the number of non-beverage standard drinks of hand sanitizer, rubbing alcohol, we measured those things. Much, much less non-beverage alcohol use for people on the MAP. Now I'm going to show you some data on their harms. We looked at about 10 domains of harm. In the first one we've got physical health, learning difficulties, violence, withdrawal seizures. You could die from a withdrawal seizure. You stop drinking suddenly. If you're severely dependent, you can have a very severe fit, and sometimes people die. It's a medical emergency, and it's not a good thing to happen. Passing out because you've drunk too much. And that carries a whole load of risks. So you'll notice much lower numbers, and the little asterisks say highly statistically significantly less of these events have been reported in the last 30 days for the established MAPs. Intermediate are the new MAPs. They're just settling into the program, and the highest in all of these dimensions are the controls. And sometimes it's dramatically higher. So, I mean, withdrawal seizures, that's actually a big number. 15% had experienced a withdrawal seizure, potentially fatal medical incidents, compared with 2% of people on the MAP. Now the other are more social domains, so the social's a bit vague. I think relationships, that's probably what it stands for. Financial problems, legal problems, police, work problems, housing problems. But all of these asterisks are saying that compared with the controls, particularly the established MAPs are having much lower rates of self-reported problems in the previous month to the interviews. So that's as far as we've got with that. This is entirely self-report data, but I think we're fairly confident because they're so open to us. They're telling us so much more about their drinking than they're telling the staff, and these are validated scales that we're using. We're fairly confident. We haven't got randomization. You know, if you're doing testing a drug, the ideal, the gold standard is a randomized controlled trial. So, you know, you either randomize to control and you know, toss a coin or whatever, whether you get the drug or placebo. We can't do that in the real world. It's very hard and there's ethical difficulties. We think we've done as well as possibly could be done, and it's certainly a step up from an uncontrolled study. So, but anyway, and we've got further to go. But there is still the problem with the data I've shown you. There will be the extent that attrition, people dropping out of the map, maybe the worst cases were leaving the map, and it's just selecting a group of people that looked good and make the controls look bad by comparison. But against that, we just say it's a highly popular, stable program. Once people got it, sometimes they can't believe, am I in paradise? This can be really happening to me? And it's such an amazing environment for them. So that over 90% we were able to follow up at 6 months because they stayed in the same place. I don't think there's much of that selection bias behind those findings. So in conclusion, enrolling and staying in the MAP is associated with safer patterns of consumption, less non-beverage alcohol use, lower daily quantities, safer than being on the street, for sure. Drinking more days per month, but with significantly fewer self-reported health and social problems. Now in future, we're going to look at long-term outcomes. How does this impact? We're going to look not just in the pilot studies, but across the country. Impacts in terms of police contacts, ER presentations, hospital admissions for this whole sample, not just the pilot. And we hope to do the cost-benefit analysis once more. So these are the hard numbers that I think the decision makers and planners need to know about whether to be expanding these programs, because I think we need one in Victoria if our data can be verified. This is too complicated. I've got the feeling that we've probably used up our time, and I'm not going to dwell. This is meant to be like a chart analysing the kinds of harms that you get from drinking. So heavy episodic drinking, you drink 30 drinks in a day and you do crazy stuff, or you pass out and get attacked, you have violence, injuries, poisonings, run into all kinds of social problems. Not the type of alcohol you use causes problems, and by the way, it's usually the ethanol that's causing the harm. There's nothing, ethanol is harmful, it's a dangerous drug, and just because it's non-beverage alcohol doesn't mean to say it's 100 times worse. It probably is in some cases, but not necessarily. I think mouthwash can be consumed with no extra risk than vodka, for example. I don't recommend it, but there we are. High volumes of alcohol consumed in the long term, risks of chronic diseases and lower life expectancy. So this is an analysis about the potential harms, how MAP may address these managed alcohol programs, potential risks. So we've had people mention, well, they just stay indoors drinking, they get as much exercise as walking to the park, they get unhealthy weight gain, there may be fewer abstinent days, so the liver needs a break. And so I personally think we need to, like Oscar Wilde used to take liver holidays. He used to go away, famous heavy drinker, and he'd go somewhere for 2 months and give his liver a break and then go back to it. But these guys, to keep them alive, and women, it's maybe pretty important they have breaks. Now, it's not ideal if they have them because they're in hospital with a broken arm or concussion, or they're in jail, but maybe that should be factored in and supported with medication. I think we have to think creatively about how to, mitigate some of these potential harms, because alcohol is a dangerous drug. Believe it or not, harm reduction programs with heroin are way safer. Heroin does virtually no harm to you. People think this is crazy. It can kill you, yes, but only if you overdose. So in the pure form, heroin will do no physical harm to any organ in your body. Addiction to it is not good. It can cause all sorts of problems in your life. As long as you don't overdose, you'll be fine. Alcohol causes cancers throughout the digestive tract. Almost throughout every organ in the body is potentially harmed by drinking alcohol. So we have to balance these risks. So we need remedial strategies to ensure that people who come onto the programs are really eligible, and it's a cost-benefit thing. What's the alternative scenario? They're being on the street, freezing to death, being attacked, robbed, whatever, to supporting them and maybe helping their lives better, but maybe shouldn't stop there. Maybe once they're stabilised, other choices should come along, and they should be informed and maybe have opportunities to decide maybe they do want to abstain or try something else. So let's just talk a bit about it, because Bernie nodded. What's this slide for, Bernie? I used to steal that summarising. I used to steal that mouthwash just to try and get myself to feel better. I was in and out of jail ever since I moved here. I haven't had any police contact. I guess that's just a nice quote summarising how people are feeling about it. So, recommendations, clear eligibility criteria for admission to the programs, monitoring of chronic harms, including liver function tests to make sure people are at death's door if you keep providing alcohol. We should explain to participants the risks of continuing high-level alcohol use, even if it's less than what they were doing before. The alcohol administration should be tailored. We found some people actually being given more alcohol on the program than they were before they went into the program, which is anyway. I think coming from harm reduction is a very good philosophy, but often I think it's laissez-faire harm reduction, and the more beverage alcohol people are given, the better, as long as they're not drinking that non-beverage alcohol. And that's not a very healthy option. So it needs to be tempered, and we need a more balanced approach, I think. Opportunities for short and longer term abstinence available on demand, and protocols to manage outside consumption of alcohol are needed. So we have a website for the project, and lots of you can find on the CARBC website. Is the CARBC thing? Is it up there? Anyway, that's a long one. You can also go to carbc.ca or UVic and look for the Centre for Addictions Research. We've got loads of our reports on this project and other materials, information about the different sites and what a managed alcohol program is. And thanks to all the researchers and knowledge users on our team, and I believe that it goes on, and our collaborators. And thank you for your attention, and hope there's time for some questions. Thank you.